Good evening, everyone, and welcome. I'm Erica Smeaton, the National Manager for Lymphoma Australia. If you would like to know more about Lymphoma Australia and the supports and the information that we have available, please scan the QR code on your screens now. It is my pleasure to be hosting this webinar tonight. Just some brief information for people who are using the Zoom platform for the first time. I'd like to draw everyone's attention to the polls that are about to pop up on your screen. If you'd like to go through and answer those questions. And I'd also like to then draw your attention to the Q&A function down the bottom in the middle of your screen. That's where you can enter any questions as well as voting for your questions so that then you move them up. And if you see a question that you would like answered, you can vote for it or like it so that then is highlighted to our team. At Lymphoma Australia, one of our missions is to provide information and support to our patients and their carers throughout their journey with lymphoma or CLL. Recently, as our southern states have encountered increasing cases of COVID and information and advice has continued to change and evolve, concern amongst our patient population has understandably increased. As most of you are likely aware, there's some data that's recently been published that shows certain lymphoma subtypes don't have the same ability to develop an immune response once vaccinated. Understandably, this is concerning for many in our blood cancer community, and you need opportunities like this webinar to ensure that you are making the best decisions for yourself based on the most up-to-date medical advice. Next screen. So the content that we'll cover in these sessions today. So the first session will be the most up-to-date information about COVID and vaccination. The second session will be the latest global data about COVID and vaccination response rates. The third session will be about Astrazeneca and clotting. And the final session, which is where we'll discuss all of the questions that have been submitted prior and any questions that come through as well too. So just use that Q&A function down the bottom in the center of your screens to log all of your questions. So the first session, next screen, please. The first session, I'd like to welcome Professor Judith Trotman, who's the head of haematology at Concord Hospital in Sydney. Professor Judith Trotman is committed to embedding research into clinical care as the founding director 2014 to 2019 at Concord Haematology Clinical Research Unit. As a past ALLG lymphoma chair, she maintained close collaborations with international cooperative groups such as the ALLG, contributing to the RAFL, REMARC, and now PETRA and RADAR trials. She provides global leadership in charting the role of PET scan in follicular lymphoma in PRIMA, in multiple studies actually. She has developed a number of digital initiatives as well with her colleagues and patients, including the ClinTrial Refer smartphone app, the MyHodgkin My Health app, and the Whimsical study, which was a global patient-derived database for patients with Waldenstrom's. Currently, Judith is an associate investigator on the Covax lymphoma study, which examines the immune response to the COVID-19 vaccination in certain blood cancer subtypes. Welcome, Judith.
Thank you. I do apologise, Erica. I wasn't ready then. I was quietly dealing with another patient problem, and so I wasn't ready to go live then. So sorry about that delay, everybody. And hello, everybody. It's I'm not going to say it's a pleasure. It's not much of a pleasure at the moment to be faced with COVID, but we do feel, along with Juliette and Julianne, our responsibility to share with you what best we know about COVID. And I say what best we know because it's such a rapidly evolving situation with COVID. And I really do have to stress that, you know, these slides were cobbled together in the last couple of days, pretty much in the last few hours, in response to the urgent SOS from Lymphoma Australia for us to reach out with you. So, you know, we'll hope that these will be of some help for you, but of course nothing is ever perfect in this rapidly changing world. These slides are also very much supported by my colleagues, Eliza Hawkes down in Melbourne, Liz Brem in California, and Wendy Osborne in Newcastle, with whom I share a lot of information about COVID. I trust you can see your slides, and if not, I trust Mike will interrupt. The first disclosure I do want to make is that we're hematologists. We're not epidemiologists, we're not virologists, public health experts, we're not ethicists, and all the opinions and recommendations here are our own, and we hope you realise that information and circumstances change very fast, so what we consider to be knowledge today might not be correct tomorrow. And we're all here because the majority of lymphoma patients have a suppressed immune system, a so-called compromised immune system. And that's because of the lymphoma itself, but also because of our very treatments for lymphoma, which cause immune suppression, which is sometimes quite severe. Immune compromised patients are at high risk of getting infections. And there is no doubt that the COVID-19, especially the current Delta variant that dominates in Australia, poses a higher risk than normal infections. Is definitely a high risk of complications from COVID-19 and immune compromised, and I've got a little bit of data about lymphoma patients specifically. But the most important message, as you all know, and as everyone around in Australia is now scrambling to get access to, vaccination is now available. And I think not just for you, but in particular for your family, your close contacts, notwithstanding the access caveats that we have around the country. Now, our role as so-called experts, as hematologists, is to use our knowledge to minimize the risk of contracting COVID for you. And obviously, I urge you all to get vaccinated ASAP, and Juliette is going to tell us a lot more of the details about vaccination in patients with lymphoma. But in particular, get your close contacts vaccinated, because I think that is, to be honest, for most patients with lymphoma, potentially the equally as important for protecting them. We're going to talk about how we as hematologists across the country, and there will always be different strokes for different folks, manage your lymphoma and its complications in this context of increased risk. And I really, and I don't apologize for this. This is a serious topic, and here, particularly in Sydney, those of you in Melbourne who've been through such significant outbreaks will also be well aware. We do sometimes have to adjust management in the context of changing resource allocation and potential reduced healthcare capacity. So I am going to address that a fair bit, because it's not just about your risk of getting lymphoma, it's about our resources, risk of getting COVID and continued treatment for your lymphoma, but our resources to help support you. So I don't think anyone needs to have emphasized more than what we've heard lately, is that vaccination works. And both vaccines work. I'm going to give you some good data that demonstrate that AstraZeneca or Pfizer, whatever you get, it works and is very good, in particular in healthy individuals. And in the premier New England Journal of Medicine, medicine's most important journal, today there was a publication showing that of 1,500 fully vaccinated healthcare workers, so in an environment with high exposure to COVID, 2.6% of them got vaccinated, and all of them were actually either asymptomatic or had mild infection with no serious breakthrough COVID-19 in that population of almost 1,500 healthcare workers. And for those of you who are active on Twitter, I've posted this tweet from the governor of New York. Only 0.15% of vaccinated New Yorkers are having breakthrough infection with the current Delta outbreak that's going on around the world. So the COVID-19 vaccines are highly effective. And if you've got other priorities you've got to do and you can't stay online for the rest of this talk, that's the one take-home message I want you to tell all your close contacts to get vaccinated as soon as they can. And indeed, I really felt just a day or two before Tagi made its announcement, before I even was aware of it, I really felt that in Sydney in particular, the risk-benefit analysis has changed, and I dared to stick my neck out and say the best vaccine. Let's stop arguing over the merits of Astrazeneca. The best vaccine is the one you can get as fast as you can get it. And that, I think, is clearly the message you're going to be getting from this first presentation. So let's just focus a little bit on the Delta variant, because we are, it is of the variants of concern, it certainly is the variant of most concern and is rapidly becoming the most dominant variant around the world. We all heard about the ferocious wave of infections in April, May, June, and ongoing in India. And it mostly affects unvaccinated people. The vaccines are effective against the Delta strain, and I'll show you some data on that. And the vast majority of current deaths due to COVID are in those who are unvaccinated. It is 60% more transmissible than the already highly infectious Alpha variant that we all heard about in sort of November, December, spreading around the UK in late 2020. So it is so infectious. And while there was a belief that, you know, in very well ventilated outdoor environments, it was very hard to transmit COVID. It is now believed that, you know, there could be transmission of Delta in, you know, crowded outdoor environments, such as the environment of all those protests that went on across the country last weekend. And there's also some early data coming out, and you know, this data might be outdated in a few weeks' time when we have even more data, but there are reports from the UK and the US that suggest that the Delta strain causes different symptoms. And a UK study reported that patients had cold-like symptoms, you know, including a headache, a runny nose, and a sore throat, more commonly as they're presenting symptoms, their initial symptoms of COVID, compared to the loss of smell and the shortness of breath and fever and cough that patients with the previous variants had. And this has been reiterated by doctors in the US. So is Delta more deadly? And you notice people ask this a lot throughout the Indian outbreak, and you know, medicine never really came out with any clear position there, and that was, you know, possibly because of the limitations of data collection and the very limited and varied healthcare system in India. But there is a sense and some early research now that Delta is more dangerous and does cause a higher rate of hospitalization and potentially death. And this increase in infections rate alone is troubling and can lead to more deaths, not just because of more cases, but simply through overwhelming the health system. And that is a risk with even the best of health systems. And that is why, you know, the Premier of New South Wales and everyone is desperately trying to hold back the wave of infections with Delta and the spread of Delta as much as we can, while we get as many people vaccinated as possible. So, you know, we are really trying to not allow a let it rip mentality go through. Now, both vaccines available in Australia are highly effective against all current variants, meaning that the vaccine reduces the chance of getting a severe illness. And when I say current variants, I mean the variants here in Australia, of which Delta is most prominent. So it reduces the chance of getting a severe illness, of being hospitalized or dying. However, it is partially resistant to people who've received just a single dose of either vaccine. And to that point, I'm going to show you some data from New South Wales Health. Now, here are the rates of symptomatic infection, hospitalization, going into intensive care, and dying. And this is the predictions based on modeling of vaccine effectiveness of the Pfizer vaccine and the Astrazeneca vaccine. Now, if you get one dose of either one, it reduces by about a third getting symptomatic infection, but it already has a 70% reduction in hospitalization. Hence the drive to stretch out the rollout of vaccination in high-risk areas in Sydney to get one dose in as many people as possible in the coming 6 weeks. And I want to highlight there in the 2 red circles, there really is no difference in the effectiveness of the Pfizer or the Astrazeneca vaccine on the modeling that is provided on the data that we have to date. Not only does each vaccine protect about 80%, 5% of the time against hospital admission or death, they also, and this is really, really important for getting your close contacts vaccinated, it reduces the onward transmission to you of COVID by more than 85%. So remember that when people ask, you know, what are the chances, or what is the risk reduction from each vaccine of both admission, death, and transmission of virus. Now, just a couple of slides, because I don't want to weigh you down with you know, being pessimistic, but I think it's important we recognize the reality that patients with lymphoma are being reported to have worse disease and a higher risk of dying because of their COVID. And this was just published very recently, and this is unfortunately what happens with publications that get put together. This is data from early in the pandemic, over 3 months in Madrid, Spain, and they had 177 patients with both lymphoma and PCR positivity for COVID. And more than 80% of these patients required hospital admission, and the overall mortality rate was effectively a third. And if you were elderly and you had other comorbidities, that was associated with a higher risk of dying. And having active lymphoma that is progressing, increased the risk of death twofold. But what was really important to note that in this study, active lymphoma treatment did not modify the mortality risk, which is a bit different to other studies, particularly in terms of those that show the impact of rituximab or oral enzyme inhibitors. This is a presentation at the European meeting just in June this year, again coming from Europe, this time from France, of 111 patients put into hospital. So not those who were well enough to stay at home, but of those who were admitted to hospital, the 6-month overall survival was 69%. And there were 32 patients who had a length of stay, hospital stay, more than 30 days, more than a month. And basically the in-hospital stay and the overall survival was worse if you were over the age of 70. It was more than twofold, twice the risk here on to the right of this vertical line, twice the risk if you were over the age of 70, if you had rituximab antibody treatment within the past 12 months, or if you had relapsed or refractory, if you had active lymphoma. And you can also appreciate that the risk is probably 1.5 times if you have other comorbid illnesses such as heart disease or kidney disease. And I think it's important to note that, again, these were patients who were hospitalized March, April 20. This was old COVID, and it was old in 2 reasons. Firstly, healthcare systems had not prepared, had not planned. And believe me, we have planned, we have planned. I think of last year's planning, last year's outbreak in Sydney as effectively being a dress rehearsal for now. but we also have to acknowledge that it was with the native COVID infection and not the more serious Delta version. So just to remind you all of what you already probably know, but just a couple of extra nuances about risk minimization, because we all know about social distancing and wearing a mask. But please, now is the time to be obsessive about hand hygiene. Make sure that the mask covers your nose and your mouth. You know, I was furious with the young man at Harris Farm in Bondi who had the mask covering his nose as he was crowding my space at the checkout. When you put on and take off your mask, make sure you've been vigilant with the hand washing and you have clean hands. Please, patients who have lymphoma really need to be shielded. You must avoid crowded spaces and keep your distance from others. And if you're indoors, make sure, I know it's winter, dress up well, but have some good ventilation and open a window and get the airflow happening. And stay away from anyone who is unvaccinated. For your own health and sanity, though, I urge you, keep up your daily walk. Whether it's a walk, I know some of you do in the garden and some of you do in not so crowded areas as Bondi Beach here, but stay masked, stay distanced or with your carer who may support you if you need to be support while walking, but also stay socially distanced from everyone else. And I thought this was wonderful, this lymphoma action, this UK lymphoma distance aware badge that I was just showing Erica about just before we started. I almost do wish that there was something similar in Australia where we could highlight our immune compromised patients and they could wear a badge and that would keep people away. I almost think perhaps the best thing is to pull out a walking stick even if you don't usually use it, because then that tends to keep people away. It is really important to maintain social distancing. So talking about minimizing risk for COVID-19 for lymphoma patients, we've talked about reducing exposure, and this is what we're doing in the hospital system. Your medical team will rationalize your visits, all right? And you've seen this happen over the past year. Your visits for treatment, your visits for blood tests, the scans, we try and avoid you coming into hospital for blood tests now in Sydney, particularly at Concord, where we're surrounded by local government areas that are high risk. But sometimes we really do need the blood test done at Concord rather than out at Douglas Hanlymore or Laverty. But generally, we're trying to get the blood test done elsewhere if they need to be done. We're trying to reduce the number of scans people need. And we, as you all know, we're doing telehealth and occasionally my virtual health meetings. I urge you to try and have at least 2 weeks supply of your oral medications. Please, please, your medical team are trying to deal with a lot at the moment. We're trying to deal with staff on furlough because of quarantine. We're trying to deal with all the many calls that we get from patients. It's really tough. If you call us 2 days before your Bactrim or your Valtrex run out and expect us to get the script to you in the mail that day, please try and think ahead and try and minimize, unplanned situations. When you have your telehealth visit, make sure you're letting your doctor know when you're going to be running out of your medications so that they can post the script out to you, or sometimes we actually post the medications out to you rather than double handling with more phone calls. Identify what your care needs are going to be if you get unwell, whether that be unwell from COVID or unwell from your lymphoma. And, to what extent can you limit the contact that you have with multiple relatives? And obviously we need to educate you all the time and you need to educate your family around you about mitigating the risks with hand hygiene and masks. the appropriate management of complications of your lymphoma and possible COVID infection. I think it's important you are well educated on the symptoms of COVID and have a plan for any potential infection. And if you get COVID, do not get in the car and come to hospital. Call us ASAP, because we want to be able to help you, but we also need to think about the ramifications of COVID from any of your contacts who've been in contact with you, whether in the health system or in your family. So call us ASAP. We obviously, if you have any complications or you're infected with COVID, we would certainly consider deferral or delay of your current treatment, but you shouldn't stop or start anything without talking to your doctor. Understand what the plans, what the goals of your lymphoma care are, and your prognosis, and what might happen in the event that you got COVID, because early advanced care planning discussions are really important so that you remain in control of your health. And look for the emergency warning signs for COVID-19, but look for the signs that require emergency medical care immediately. If you're really having trouble breathing, if you've got persistent chest pain, if the person who you're caring for who has lymphoma is getting more and more confused, along with a known diagnosis of COVID-19, and any of those symptoms there, they're some of the emergency warning signs where you probably do need emergency medical care if your loved one has COVID. And call 111. Sorry, call 000. I'm a New Zealander. So managing lymphoma and complications in the context of increased risk. Don't delay going to hospital for emergency care. And that stands true whether it's emergency care for your lymphoma, your heart disease, any other medical problem, or emergency care for COVID. We obviously make decisions about whether to treat or defer, and most patients should continue their treatment. And this is in the sense of risk of COVID, not actually when you've got COVID, although even when you've got COVID, some patients need to continue their treatment. And we need careful selection of the regimen, the recipe of chemotherapy or treatment for lymphoma, and optimize our supportive care. And we also are increasing our safety nets for you in the context of our reduced contact with you. And there are numerous factors that come into the decision making here, the patient considerations, the therapeutic choices, the supportive cares, whether we need to treat you as an inpatient or an outpatient, and when we start treating, what are the trigger points for initial treatment, and why we're treating, the risk to the individual compared to the risk to traffic to organisation and the staff and other patients. I do want to mention one or two slides on the impact of resource allocation, because the impact of COVID has reduced our ability to provide standard care. We're still, I believe, every centre around the country is still providing high quality care, but it is a different business as usual, which tends to keep changing every week or every day. You've all experienced telehealth, the video system that we try to introduce for some patients in some hospitals is very clunky, and very often we're finding a phone call is better, because talking to someone on the video with a mask is very difficult to communicate, and sometimes just focusing on what they're saying over the telephone is a lot better. However, we appreciate that some patients are hearing impaired, or some of their carers are hearing impaired. The visiting restrictions, particularly, where one of you would come with your partner to the outpatient clinic and you're no longer able to be there, or if your family members can't be there with you when you're in a hospital, that causes a huge impact on family support and advocacy and communication. And we do try to to phone the family members of our inpatients as often as we can. And as I said, the masks and social distancing really do change interpersonal communication. Resourcing constraints are slowing the turnaround times for testing. We've cancelled a lot of surgical clinics. We have staff shortages due to quarantine or their own illness because they've got their own runny nose, so they want to keep away. And there are sometimes medication shortages because of supply chain issues. But what we haven't had, and all credit to the Red Cross, is any significant delays in blood products or delivery of transplant to the various transplant centres from donors around the world, delivery of the stem cells. And that's a credit to the Red Cross and to all those blood donors out there. There are also differing policies of external providers, other departments, other institutions, pathology services around the country, radiology services, private hospitals, particularly nursing homes in terms of, delayed discharge to nursing homes because of waiting till COVID testing's been done, and the limitations in community service delivery. I'm sure you are all experiencing many changes that have been listed there. But let's always think of a few bright things on the, the silver lining. There have been some additional changes, and I'm sure many of you have been very happy to be out shopping or out having your walk when I call you for your telephone consultation. None of us have had influenza recently, but that might change. We're getting, perhaps our ambulatory care patients are comforted by having the regular COVID surveillance swabs. We have registered Australia Post delivery of many oral medications now to save patients coming into the hospital. Many of you have changed in the past year from intravenous immunoglobulin infusions in the ambulatory care to subcutaneous infusions at home while watching Netflix. And we like to hope we're turning patients around faster so they're not exposed to the healthcare setting for as long, they're better spaced. And I'm very pleased that Gladys is allowing a bit of reconstruction to occur in Sydney so that next week our new Concord Cancer Centre will commence its last few weeks of its build. So one final slide about, I think this is the near final slide about the impact on resource allocation. Unfortunately, resourcing decisions do need to be made. Decisions for the extreme situation, the very high intensity curative intent treatment for lymphomas from which people will otherwise die within days to weeks, are a lot easier than the middle ground decisions. Some of these decisions are a bit out of our control, and communication on all sides is really important. And the ethical principles of equity, proportionality and transparency apply to all resource allocation decisions. Questions I ask myself in management decisions are, what is the risk of my decision to the patient right now and in the future? Not just the immunosuppressive risk of the treatment, but the risk of the frequency of visits, the patient's vulnerability because of their other comorbidities and their age. What is the true survival benefit of what I'm doing? Is there any safety to defer therapy? Are there alternatives which say less intensive therapies with similar survival outcomes? Are there oral options that are just as good as intravenous? And what about enrolling patients to clinical trial? Is there a greater potential clinical benefit for them to have this novel agent on study, or is it safer just to give them standard of care chemotherapy? And we discuss these things all the time in our department in our multidisciplinary team meetings around the country. So to summarize, a lot of the data I've given you here are only estimates because there is limited data measuring risk in an evolving pandemic. We really can't actually quantify how much more at risk of COVID-19 lymphoma patients are. We don't know the actual difference in outcomes. We know they're inferior, but we don't know the exact difference in outcomes of COVID-19, particularly due to the Delta variant in immunocompromised patients. We try to be consistent. We try to keep up to date with the current recommendations, the numerous policies that we get from our own institution, from the state, from the federal government, the information we get from the CDC and other international authorities, from the WHO. We try to make our decisions with our clinical peers based on the best available data, and communication as much as we can is important, but being timely and accurate all the time is very challenging, I have to admit. And it's important that we communicate both decision and uncertainty. And we also think it's really important, a telehealth appointment is not shortchanging you. They are just as important as a visit to the hospital. So please be close to the phone in the hour or two around your telehealth appointment, because your hematologist often can't call you at the assigned time. Their telehealth clinics may go very rapidly, so they may call you earlier, or they may go very slowly and they call you later. And we definitely want to be able to have someone answer the phone when we call. We mitigate the other risks of treatment in the disease as much as possible, shielding you from exposure, maximizing vaccination, and giving you all the supportive cares that you need. And with that, I give you my message number one, the take-home message: get vaccinated and get your close ones vaccinated. And I'll stop my screen share there.
Thank you so much, Judith. The questions are coming in very quickly. It's obviously such a hot topic at the moment.
Right.
We'll save all the...
I'm afraid I ignored the 42 Q&A notes. Hopefully Juliette and Julianne have responded to a few of them, fielded a few.
Well, I'm madly taking notes and trying to get down as many questions as possible, but I don't think we'll be able to get through all of them, but we will download the questions and get back to people as well too, and post them through our socials.
Sure
so
will. Yep.
Yeah. So thank you for that. Moving forwards though, we'll now move to Dr. Juliette Raedemaeker, who will be discussing the latest global data on vaccine response in lymphoma and CLL patients. Dr. Juliette graduated as a medical doctor from University Catholic de Louvain in Belgium in 2015. I did practice this to try not to butcher it, sorry. She did her specialist training in Belgium and obtained an internal medicine specialist title in 2020. Currently, she's doing her final year of haematology training at Concord Hospital in Sydney, where she'll work in Australia until the end of the year and then move back to Belgium to practice as a haematologist. Welcome, Juliette.
Thank you, Erika, for the introduction, and you pronounce my name very well.
Thank you.
So now I will talk about the latest data about COVID-19 vaccine in chronic lymphocytic leukemia and lymphoma patients. First, I will just quickly review how COVID vaccine works and how we assess the vaccine response in clinical trials. Then I will present you 6 recent studies that summarize what we know so far about COVID vaccine, and then some key messages. So first, here in the right upper corner, you can see a representation of a COVID-19 virus. In red, you have the spike protein. So it's a protein at the surface of the virus. And it's this protein that is used in vaccine to trigger the patient's immune response. So the first type of vaccine is the famous mRNA vaccines, the Pfizer and the Moderna. Then you have the double-stranded DNA vaccines, the Johnson & Johnson and the Astrazeneca. And then you have the more traditional vaccine, the Novavax. The Pfizer and the AstraZeneca that are underlined and in bold are the ones that are most commonly used in clinical trials. So for the mRNA vaccine, the mRNA is actually the genetic code of this spike protein. So the mRNA is going to be injected to the patient, then enter the cell. it will be a red inside the cell to produce this spike protein that will be then exposed here at the surface of the vaccinated cell. For the double-stranded DNA vaccine, they are using another trick. They are using this adenovirus that has been modified, so it's not able to replicate when he is inside the patient's body. And so this adenovirus is acting like a Trojan horse. It's gonna enter the cell, travel inside, and drop his package here at the center. This DNA will be transcribed into, again, an mRNA, and this mRNA will again help to produce the spike protein that will be recognized by the immune system. In the traditional vaccine, they are just using the spike protein. So here you have the two kinds of response that are triggered by the vaccine, the antibody response and the cellular response. In the antibody response, you will see here that you have the spike protein at the surface of the vaccinated cell. And these B cells are the immune cells that are gonna help produce the antibodies, and these antibodies will respond in case of infection. Same for the T cell. They will recognize the spike protein at the surface of the cell, and this activated T cell will recruit other immune cells, and they will work with the B cell to produce an efficient immune response. So how do we assess this efficient immune response in clinical trials? We are using the antibody level, and the antibody specifically is the anti-spike protein IgG antibody, because we want to know if the vaccination works, or if we were able to trigger the immune system to produce this antibody. If you read a bit more about clinical trials and vaccine, you will also see this anti-nucleocapsid protein antibody. It's actually the first antibody to be produced when you are infected with COVID-19 virus. So it can help to discriminate people to know which one had an immune response from natural infection or from vaccination. Also, we use the neutralizing antibody activity, so we can then assess the capacity of the antibody to actually fight the COVID-19 virus. And this activity can be different depending on the variant. And then they try to assess also the T cell response. So the T cell are just a subtype of immune cell of lymphocyte. They are working with the B cell to mount a good immune response, either to infection or vaccine. And we can quantitate the T cell, and we can also assess their functional activity. So now I will present a short overview of the actual data. Here we have two studies that were published recently with heterogeneous group of cancer patients. The first one assessed the antibody response rate among 200 cancer patients, but only 26 had lymphoid malignancy. So lymphoid is lymphoma patient, CLL patient. They were vaccinated mainly with Pfizer and Moderna. Only 10% had the Johnson & Johnson vaccine. And sorry for that, they tested the anti-spike protein antibody after vaccination. And what they observed is that they had the same antibody response for Pfizer and Moderna, but they had highest antibody level with those mRNA vaccine when compared to Johnson & Johnson. Also, patients with solid cancer, so it's lung cancer, colon cancer, everything that's not blood cancer, they had better antibody response compared to blood cancer patients. Patients that were on active chemo, that have had recent stem cell transplant, that were on anti-CD20 therapy, it's the rituximab, the MabThera, or the obinutuzumab. Patients with recent novel therapy, the CAR T-cell, they all had lower response. Also, there was a link between time of treatment and vaccination. Patients that had received the treatment within 48 hours of vaccination had lower response. The second study assessed the difference between one dose of vaccine and 2 doses of Pfizer vaccine. It's a study in 151 cancer patients, 56 with blood cancer. And so some of them had the regular schedule of Pfizer vaccine, 2 injections, 10 to 1 days apart. And some of them had a delayed boost at 12 weeks. And here they tested the antibody, but also the neutralizing activity and the T-cell response. It's only the interim analysis, so we just have the baseline and the 5 weeks evaluation. So after 1 injection, so at 3 weeks, they saw that, no surprise, the group control had 98% of response, but in hematology patient, only 18% had antibody. At 5 weeks, the hematology patient that had received the booster, so the second injection, had increased their response to 60%. And the one that only received 1 boost had only 11% of response. Another interesting fact is that patients that had good level of antibody actually had a high neutralization capacity, meaning an efficient antibody that were really able to fight the vaccine. They also saw that some T-cell response was observed in patients with no antibodies. That was also interesting. And there was also a link between time to treatment and vaccination. Many non-responders had received the treatment within 15 days of vaccination. Here, it's a quite large study with 885 patients, only with blood cancer and vaccinated with Pfizer vaccine. It's a Lithuanian study. They tested only the antibody and they presented their results according to the treatment received by the patient. They observed a good antibody response for patients on TKI. So TKI, it's the imatinib, ponatinib, or dasatinib. Also good response for patients that were at least 6 months post-allotransplant or autotransplant. But in contrast, low response when patients were within 12 months or anti-CD20 therapy, so the MabThera, the rituximab, or the obinutuzumab. But they observed that after 12 months, patients started to improve their antibody response. Also, low response where a patient were on oral BTKA, it's the ibrutinib or zanubrutinib, patient on ruxolitinib or BCL2 inhibitor, the venetoclax. And also when patient had good response after 1 dose, the booster, the second dose, mounted a high increase in terms of antibody level. Next, we have a study just on a chronic lymphocytic leukemia patient assessing the antibody response with Pfizer vaccine. They included 167 patients versus control. Only 40% of CLL patients had antibody response. The criteria associated with good response were younger age, so less than 65 years old, being a female, having an early stage and good prognostic CLL, and having good immunoglobulin levels. Patients that were never been treated before or that had stopped treatment at least 12 months ago also had good response. Same for patients that were in remission after treatment. And again, no or low response was observed when patients were within 12 months of anti-CD20 therapy, so the rituximab, the obinutuzumab. Same for patients on active treatment with BTK inhibitor, the ibrutinib, zanubrutinib, and the venetoclax. But if patient had stopped for at least 2 months prior to vaccination, they had better antibody level. And then 2 studies with only lymphoma patients. The first one is the Prosecco UK study, 129 lymphoma patients versus control healthcare workers. They were vaccinated with Pfizer and Astrazeneca. They observed no response in 61% of patients that were vaccinated within 6 months post-therapy. Also, poor response in indolent chronic lymphoma, for example, follicular lymphoma. All patients had reduced antibody level irrespective of their treatment history. But in contrast, good response was observed in Hodgkin patient or B-cell non-Hodgkin lymphoma like DLBCL, for example, if patients were vaccinated at least 6 months post-treatment. And again, there was no difference between the Pfizer or the Astrazeneca in lymphoma patients. And the last study again tested the antibody response in lymphoma patients, but specifically on patients receiving B-cell directed therapies. So we saw at the beginning that the B-cells are responsible for the production of antibodies. So we can suppose that if a drug is interfering with the production of antibody, patient will have some difficulty to mount a good response to a vaccine. So here they included 86 B-cell lymphoma patients. All vaccines were allowed, and again, they tested the anti-spike protein antibody, and they presented their result according to the time from last treatment. And what they saw is that only 9.7% of patients that were on therapy or within 3 months after treatment had an antibody response, and the one that responded had lower antibody level. But interestingly, there was an increase in antibody response over the different periods of time, meaning that they observed good response when patients were at least 9 months post-therapy. So what can we learn from those data? First of all, there is no difference from Pfizer or AstraZeneca. When lymphoma patient or CLL patient have antibody response, these antibodies are efficient to fight COVID-19. Poor response were observed when patients are on active chemo, are on ibrutinib, zanubrutinib, venetoclax, and anti-CD20 therapy, so the rituximab or the obinutuzumab. But good response when patients are in remission or have completed treatment at least 9 months ago, and further away patients are from treatment, better is the antibody response. So the key messages is that just get vaccinated as soon as you can, because low response is still better than no antibody. And even if you don't produce antibody, we saw some T-cell response in the non-responder, so that could also protect you. Vaccinate your family members, your close contact, because it will protect yourself and all the immunocompromised patients. Continue to follow the social distancing, the hygiene, embrace the telehealth, virtual health consults whenever it's possible. The big question now is what about a booster? So definitely some patients may benefit from booster. There are studies ongoing. So we saw here that further away patients are from their treatment, better is the response. So we can definitely suppose that if you have a third injection, you can, trigger a better response. And also we saw that with the second injection, you had a significant increase in your antibody levels. So we can also suppose that a third one would also help increase a bit more these antibodies. So what we are doing now at Concord, we are doing the Covax lymphoma study. We have recruited 85 patients between May and June, 37 with Waldenström macroglobulinemia, 35 with follicular lymphoma, and 13 healthy controls. We stratified them depending on their treatments or no treatment, chemo, and patient on ibrutinib or zanubrutinib. We vaccinated them with 2 doses of Pfizer, and we assessed their antibody level, their T-cell response, and also the neutralizing activity of the antibodies. We did that at baseline, then the day of the second shot, so at 3 weeks, and 1 month post second dose. That's what we are doing right now. And we are also hoping to have a 6 months blood test post second injection. It's a project that we are running with the WMOZs and the Kirby Institute, and we are hoping to have the first results by October this year, and maybe expand the study to include booster later in the year. Thank you for your attention.
Thank you so much, Juliette. I think that answered some questions and raised some more questions as well.
Yeah, probably.
Yeah, I think that's to be expected though as well too. I think I'd just like to highlight a couple of things that you said as well too, because I'm watching the chat feed and there was a couple of things that you answered as you were going through as well too. So I wanted to highlight what you said about mounting a good response 6 months post allograft as well too, because I've seen quite a few questions come through looking for allograft specifics. So I think I'd like to highlight that because it answers some of the questions. And then also as well too, that in more than 40% of patients with CLL as well too, they also mounted a good antibody response as well. So thank you so much for that. And I'm sure there's more questions coming through for you shortly.
Probably.
So we'll move forward into session 3 now. So session 3 is about Astrazeneca clotting and vaccine-induced thrombocytopenia. So this session will be conducted by Dr. Julianne Falconer, who completed her clinical and laboratory hematology training primarily in the Western Sydney area, as well as Peter MacCallum Cancer Centre in Melbourne. Currently, she's the thrombosis and hemostasis fellow at Concord Hospital, primarily looking after patients with various bleeding and blood clotting issues. During this COVID pandemic, though, the role has evolved and now involves providing advice about vaccine-associated thrombosis and facilitating further investigation and management. Welcome, Julianne.
Thanks, Erica. Thanks for the invite, everyone. I'm glad to be with you. I'll just see if I can successfully share the screen. How's that? All right, so I'm just going to do a very brief session on some of the information surrounding the clotting side effects of the Astrazeneca vaccine. And as Prof. Troutman was saying, you know, particularly as the cases are increasing in certain parts of Australia, we just really need to be thinking for vaccination for, you know, vulnerable people, but also particularly those surrounding those people. And so I imagine a lot of people thinking about where to find good information with regards to the risk benefit, particularly with this in mind. And certainly I can give you some ideas as to where to look to direct not only you, but those around you to have a look at some further reading. So the COVID-19 vaccine immune thrombosis and thrombocytopenia, this VITT is what we've been calling it for short, and basically it's just a vaccine-induced thrombosis thrombocytopenia. It's sometimes also called thrombosis thrombocytopenia syndrome, or TTS, so you might hear that interchangeably. Essentially, it's a very rare immune condition. It involves unique antibodies that patients who have unfortunately had this complication have been found to have, and it's an antibody related to platelet factor 4. So the function of the platelet factor 4 in the body usually is to act as a bit of a signal for platelet activation. And as I'm sure you know, platelets clump together, they go to a site of injury, and they can form a plug to set off a cascade of appropriate coagulation. Unfortunately, in the context of these antibodies, this activation of the platelets occurs inappropriately and can set off a little bit of a cascade of blood clotting that can lead to blood clots in blood vessels and thrombosis, as well as a low platelet count as you're getting consumption or of those platelets in the process. So who gets VITT? As we know, the VITT has been associated with the Astrazeneca vaccine in particular. We found that the first dose has been largely associated with this particular side effect, and quite a lower risk with the second dose. We found that men are just as likely as women to get the vaccine. There's no particular disproportion from that perspective. It can affect people of all ages. Of course, that may have a little bit of relevance in terms of the vaccine rollout and who's been receiving the Astrazeneca. But in general, we've found with regards to VITT that 1 in 50,000 cases of people above 50 years old, and about 1 in 35,000 cases of VITT in people less than 50 years old. So those are kind of your risks in terms of this VITT entity when having the AstraZeneca vaccine. Very important to note, however, though, that of those numbers, really only 3% of those cases who have had VITT have actually passed away. So that's really less than 1 in a million that we, in terms of mortality rate. There are no identified risk factors for developing this condition. So even if you've had a past history of clot, though it's advised to have a chat to your doctor further, we really haven't isolated any particular increased risks in certain people compared to others. This is probably a very important thing to keep an eye out for. It's good to educate ourselves about what to look out for if we are considering the AstraZeneca vaccine. And really, the symptoms timing is very critical. So the vast majority of cases have occurred between 4 and 42 days after having the AstraZeneca vaccine. And as I mentioned, far more common with the first dose than the second. The most common symptoms have been headaches, chest pain, shortness of breath, leg swelling, and persistent abdominal pain. And those symptoms relate to the various sites that the blood clots may occur in. It has been quite common, particularly to have clots within the veins in the head, so relates to the high incidence of headaches as a presenting feature. That can be associated with some additional features. So often it's quite a severe headache, so paracetamol may not assist in resolving the headache completely. Sometimes associated with other features such as some visual changes and nausea, things that would be out of keeping with sort of a typical headache commonly. And important to note that the likelihood of getting clots in the veins in the head in the general population outside of the context of the AstraZeneca is quite a lot lower. So it is quite a pronounced sort of presentation in terms of unusual site for getting a clot. Similarly, clots within the vessels within the abdomen is considered quite an unusual site to get a clot in general. So certainly having these thrombotic episodes and symptoms relating to them in these particular sites is a little bit of a warning sign that it may be consistent with this VITT diagnosis. Of course, chest pain, shortness of breath may be associated with clots in the lungs, and leg swelling, deep vein thrombosis. So in terms of diagnosis, of course, we're relying on the medical assessment, so looking at both the timing and also the sites of the thrombosis and the associated other symptoms to assess as to whether we need to do investigations with some imaging to look for clots. We concurrently do some blood tests, and as mentioned, we do tend to see a drop of in the platelet level in association with this problem as those platelets are being consumed within a clot. So that's been a very sensitive marker for us to be able to identify as a sort of initial screening as to whether people need further testing for concern about this issue. We've got some other blood tests that we can do that can be we can get some rapid results for that give us a little bit of information about the activation of the blood clotting system. And then certainly we can send off very particular tests to look for the presence of these antibodies to the PF4 in the blood. So in terms of treatment, I think it's important to highlight that we treat the blood clots with blood thinners, and we also have had a lot of success in terms of particularly IVIG, and perhaps many of you in the lymphoma setting would be quite familiar with the IVIG infusions, and steroids similarly, as well as IVIG, can really help to stop this immune process, which is sort of the basis of this dysregulated abnormal clotting. So we managed to, if we identify these issues very quickly and we send off the appropriate testing, the treatment tends to be very effective in the setting. Lots of work has been done, as Erica mentioned. I've been involved in a lot of the education for practitioners and for patients, just to raise a little bit of awareness in the rare event that VITT may occur in association with AstraZeneca, ensuring that everyone has a very clear idea as to how to access information to assess people in a timely fashion, and with all the appropriate tests to be sent. And our emergency departments and GPs and other specialties within the hospital have been calling us when necessary to get some extra guidance, and they've done a really fantastic job of also keeping up to date, as we have, of course, about all the developing information we have from the studies, to be able to quickly assess and quickly treat these issues when they do come about. So just thought we'd quickly have a chat in the current climate, certainly obviously Sydney, Melbourne and lockdown, but thinking about the various spots that everyone might be calling in from around the nation. Essentially, when we're considering vaccination, there's always that risk benefit that we have to consider. So the Delta strain, of course, is of great concern at the moment in terms of how infectious that is, and how significant that is in terms of impact, as Prof. Troutman mentioned. Of course, the personal risk in terms of being immune suppressed, and ensuring that those around you are vaccinated if you're not able to have a vaccine, or have perhaps a reduced response to vaccination, certainly has to be taken into account. And obviously the rising case numbers, we're acutely aware in Sydney in particular at the moment, really is tipping that balance in terms of how we're considering risk, and that's a little bit of an explanation as to how some of the messages have changed over current months, in terms of what age groups we're considering vaccinating with which vaccines and whatnot. So a little bit of background as to how we ourselves are balancing those risks in terms of advice as well. A really important part is looking at the waiting time to receive vaccination as well. So on the flip side of things, looking at the thrombotic risk, in terms of the numbers that I presented before, so about 1 in 50,000 people above the age of 50 who have had the AstraZeneca vaccine have had a VITT complication. About 1 in 35,000 of those below the age of 50. So Melburnians might recognise that picture as being the MCG, which holds approximately 100,000 people. So it's a nice little visual to sort of conceptualise that degree of risk. So perhaps, you know, 2 in 100,000, 2 people within that stadium above 50. If everyone in that stadium was vaccinated with AstraZeneca, may have the VITT complication, and approximately 2 to 3 people of those less than 50 in that stadium. So when we're thinking about risk, and certainly with the rising risk of numbers in the community, it's a good way to think about it, and certainly having a chat to your doctor and considering those risks for yourself in the context of the COVID infection is really important ongoing. And just a further little comparison, this is a nice little schematic that looks at risk of death per million, and you can see we've got you know, car accidents. Obviously everyone's traveling around in cars every day. a lot more significant a number than death from the Astrazeneca clotting complication, which is about in the same range as being hit by lightning. So I think contextualizing that risk and considering all the factors that go into the decision making around which vaccine to choose is very important. From my perspective, obviously a lot of the discussion that I've had have been with patients and doctors looking after patients with clotting problems in particular. So certainly providing a bit of additional guidance. In that context, there really is quite a short list of patients as well with very particular clotting disorders that we've exercised a little bit of additional caution in terms of the AstraZeneca, but you know, that individual sort of risk assessment is important to discuss with your doctor. But you know, in the vast majority of people, the risk really is very small. So I just put a little reference section here for really helpful resources to consider if you're wanting to do some further reading and consideration. I know that's a lot of information out there, and it's really hard to consider it all and to sort of take it in and weigh all the risks, but these are some very clear guidelines provided, particularly by ATAGI. So that's the Australian Technical Advisory Group on Immunisation. They're directly involved in advising the Minister of Health on National Immunisation Program and other immunisation issues. And they put out a joint statement which is available online, that's in association with Thrombosis Hemostasis Society, which the coagulation specialists from hematology in particular are a part of, to share up-to-date information and help develop guidelines. And that really gives a very good, clear outline of basically a lot of what I've been through already in terms of this TTS or VITT syndrome, and you can have a further read there. I took some of the information as well in terms of the weighing of the risk from a couple of really good articles recently in the Sydney Morning Herald, just looking at that the balance of those risks as well. So a lot of reassurance that there's a lot of work going on behind the scenes here to make sure that we're really collating all of the cases that we have identified as being consistent with this VITT entity. We're very efficient and diligent in ensuring that the process of testing and prompt management in the rare circumstances that people have had the VITT are proceeding, and obviously we continue to provide a lot of guidance as needed to your GPs and your specialists about you know, decision making going forward and any concerns they might have. So I might put it back to Erica, and I don't know if there's any questions that we want to start filing through in particular. I'm very happy to answer any about clotting things, but I'll pop it back to you.
Thank you so much. I think Judith has been powering through answering some of the questions already on the Q&A, but I don't think you can keep up. The questions are coming in too fast. I'd like to welcome Julianne and Juliette both back as well too, while we facilitate some questions as well too. So I wanted to highlight a couple of things as well too. So those website links that Julianne shared as well too, we'll also have them up on the Lymphoma Australia website tomorrow as well too, if you missed them, so that then you can go and have a look too. But I wanted to highlight a couple of questions that have probably already, I think Judith has answered as well too, but just to highlight for the group because they're common themes amongst a lot of questions. So one of the first questions is, will a booster be available and recommended for immunocompromised patients?
Okay. The simple answer is in the future, probably, but that requires a bit of crystal ball gazing. You will have all heard that in England, in certain parts of the world, the CEO of Pfizer has also come out and said boosters are likely, particularly for elderly people, because they have what is called a senescent immune system, and their response to vaccine tends to wane over more than younger people's. So even without lymphoma, there's likely to be booster vaccines required, not just because of waning immunity, but as we're seeing, COVID changes. You know, the COVID we had in January 2020 in Wuhan is very, very different beast to the COVID we've got here in Sydney now. So I predict that everyone is going to be getting boosters, and people who are immune compromised and elderly will be the first in line. So that pays to the question of people saying, when I'm having chemotherapy, you know, should I get vaccinated now or should I wait till after my chemotherapy? And that is an incredibly complicated question to ask, but one that you've got to ask your hematologist, because everyone is different. But my gut feeling and my general gist when I'm treating patients right here and now, we're not July, we're still July 2021, is if you're in the midst of chemotherapy, I don't give them the vaccine, and I wait for at least a few weeks, ideally a few months. You know, I try to crystal ball and predict the shifting sands, right, after they've completed their therapy, if I think they're going to complete their therapy this year. And I make sure their partners and their close contacts and their adult children and their adult grandchildren are all vaccinated. They've got a ring of steel around them, all right? That's so important. Everyone focuses on themselves, all right? That's human nature, but it's the people around you that protect you. They are your best protection. If someone is, say, having treatment that isn't going to be finished for a couple of years, because I think they need to have ongoing maintenance antibody treatment or something like that, I say go and have vaccination, because it makes you feel good, all right? You might not mount a very good antibody response, but you might mount a T-cell response. Even a not so good antibody response might provide some protection. If you get COVID, then at least you think, well, you know, I did everything I possibly could to help prevent myself getting COVID, because by the time, you know, you've finished your treatment, there'll be a booster vaccine available for you now. You know, vaccination is safe. All right, it's for the vast majority of people, vaccination is safe. So primum non nocere, do no harm, do something that is safe, even if it's not going to be as effective as it is in a normal immune competent individual. As to boosters, yes, they're likely to come. What boosters? This is where we're going to really need your help, and this is where we've been so grateful for the WM patients, the follicular lymphoma patients who've participated in our study, because they'll be first in line for what we call as a protocol amendment in our clinical trial, because if they don't mount a good antibody response, then we're going to be giving them a booster vaccine. Now, herein lies the trick. If you've had Pfizer, and then 3 weeks later, you've had another Pfizer vaccine, there is data coming out that suggests that if you had zero response and then you have zero response, it's probably not much point giving you another Pfizer vaccine as a booster, right? And that makes sense. You don't have to be a brilliant scientist to realize that, unless your immune system has changed in that time. You know, you've recovered from your treatment for Hodgkin's or aggressive lymphoma, and your immune system is coming back at a much more rapid rate than, say, someone with chronic lymphocytic leukemia or follicular lymphoma, right? Then you might mount a response because you've had the benefit of time, right? Boosters come later, so that helps as well. Time helps. You're probably not going to mount a very effective additional response to Astrazeneca, but it might be better than another Pfizer. There is some data saying Pfizer, AstraZeneca doesn't work as well as AstraZeneca, Pfizer. But this is only really, you know, small data. And we've shown in the real world that AstraZeneca has been a lot better in reality than it has performed in clinical trials. So, you know, the true test of vaccine response is, did you get COVID? Not did you get an antibody response, or how well your T cells responses. Were you protected from COVID if you were exposed to it? And we're actually going to be talking, we're thinking maybe Novavax, a protein-based vaccine, a different vaccine, might be a good way to boost people if they haven't responded to the Pfizer. So I'm so sorry, that was a really long response, but there's lots of booster questions coming through here.
There is a lot of booster questions.
Because I thought we'd do the generic response.
Yes, no, I think that's good. And I think you answered some other questions as well in there as well too about antibodies, because that was going to be my next question as well too. Do you think that antibody testing should be done routinely for immunocompromised people?
No, if you do antibody testing, I mean, all right, there are the pragmatic things here. And I know there's a few things saying, you know, like the spacing of the vaccines, is that a political decision or a scientific decision? It's a scientific decision. It's a practical, political and scientific decision, all right? Political decisions are based on science and humanities, all right? And it's about getting as many people that first vaccine as possible to protect them. Now, what was the question again? It was about antibodies. Yeah. So
you're being flooded with questions.
If everyone goes racing in, think of the impact on our immunology laboratories if everyone goes racing in to get their antibodies checked around Australia, right? The immunology service in Australia would crash, is my opinion, all right, until it's, you know, got the infrastructure support to provide a validated, you know, a NATA accredited, validated, reliable test that correlates antibody titer with COVID protection. We don't even know. I'm amazed. All right. I said to my immunologist colleagues at the Kirby, what have you guys all been doing? What have the immunologists been doing for the last year? We still don't know. And I say that tongue in cheek because they've all been working really hard. We still don't know what is the sweet spot. What is the antibody level that protects people from getting COVID? In, you know, translating what's in the lab, right, to what's in the real world. So we don't know what these antibody test results really mean. So they might give us a lot of comfort or dismay without necessarily telling us the real situation. So we need to know more before we can have a proper test. And then once we get a proper test, be assured it will roll out around the world very quickly, and it'll be a reliable test. You know, there's one thing worse than no test, and it's an unreliable test. And if we start having unreliable testing swamping the system, then patients with CLL are not going to get their immunoglobulin levels checked. Patients with Waldenstrom's are not going to be getting their IgM levels checked, you know, in a timely fashion that we need for proper care. So, you know, we need to just dampen down the enthusiasm for going to your GP or your hematologist and asking for antibody testing. And I'm really pleased none of my patients have dared ask for it.
I was going to say, do you have a badge that you wear that says that so they know?
No. I like to think that they know that I'd be recommending it to them if we felt it was important. And there might be some time in 2022 when we are.
Yeah. I wanted
Juliette and Julianne, can you add to that? Because it's just my opinion. What do you feel?
Yeah, and I think we don't really know about what's the threshold to say that antibody are sufficient, and we also don't know if they are working efficiently. So yeah, don't think it's the right time to test everyone.
Very good. All right, Julianne, did you have anything to comment, or are you both in agreement with Juliette and Judith?
I was just going to quickly say a very good point by Prof. Troutman that we need to be a little bit mindful of workflow and not stopping up, you know, sort of important timely turnaround of testing for things that you know, it's really tricky to sort of interpret. So really key.
That may not mount any sort of meaningful data just yet.
Yeah, and we get asked, lots of people say, when are you going to have the data from your study?
Please. That's on my question
It'll be through when it's ready, when it's safe, when we think we've got reliable data to tell people. We're not going to be tweeting this out. And then there's also this tension. You've seen a lot of the data comes out in a sort of pre-release before it's undergone peer review. And that's really important. But there's a tension there between being quick and being right. It's
getting the balance. So I wanted to come back as well too, because you did briefly touch on this as well too, and a couple of questions have come through about it as well too. Is there any scientific justification in the allowance of delaying the second injection from 3 to 6 weeks, as the New South Wales government has recently done?
Well, there's clearly a scientific justification for the population, all right? For the individual, which is what the question is, obviously, I thought there was some data suggesting that if you had a delay to the vaccination, you might mount a slightly better response. And please correct me, Juliette, you're probably the one who knows the best here. But think about that. Think about the time. If you delay, you're testing later. And so you're going to have mounted a better response, all right?
I don't think it has.
I don't think there's been a big advantage. Yeah.
Yeah, I don't think maybe in the general population, but I don't think it was correlated for the immunocompromised patients.
Yeah.
Yeah. Okay. You did briefly touch on this as well too, but Judith, what do you think about if you're currently on maintenance treatment and COVID was a growing concern in your area as well too? Should the maintenance treatment be withheld for a duration of time to allow greater immunity to the vaccine? Like, again, the balancing act.
Again, this is a balancing act. But basically, the simple, and this might sound really flippant, and I'm not being flippant here, but stopping your maintenance antibody treatment will have effect in 12 to 24 months' time. Now, so I tend to sort of say, if you've committed to maintenance, if your hematologist and you have decided together, because it's not a decision for your hematologist to make, it's a decision to, for you to make in conjunction with your hematologist. If what's called the progression-free survival advantage, the advantage in delaying the time that your lymphoma comes back, and the time to next treatment advantage that you do get, it's not nearly as much as the progression-free survival advantage. The time to next treatment advantage that you get from having maintenance rituximab, MabThera, obinutuzumab, Gazyva, any maintenance antibody, is believed to be a big priority for you, then you won't stop the antibody, even with the COVID around you, because you've got your shield, you've got your wall of steel and your vaccinated family, right, and friends, and shielding yourself from, you don't go to the supermarket, someone else goes to the supermarket for you. But if you're having toxicities of the antibody treatment, you're getting too much sinusitis, too much bronchitis, you don't want to be coming in and out of the hospital, you might want to stop the antibody treatment. But the effects of the antibody treatment will take a long, long time to wear off, particularly if you've had a more immune suppressive chemotherapy like bendamustine. Yeah. So it's a trade-off question. I think the most important thing is if you stop now, it is not going to affect your risk of getting COVID now.
No, and it doesn't.
Patients who've seesawed, who wanted to stop and then wanted to start again, and then wanted to stop, and it was just. And that's why we're doing the Portray study, to work out what is the trade-off in the risks and benefits equation, because we really don't know. We really don't know. And there is no overall survival advantage to antibody maintenance. It's really important to appreciate that.
Okay, so I think that what you're saying as well too is it's not just a simple trade-off about stopping treatment. It's multi-layered approach to then doing the things around you, putting the shield around you with the people around you being vaccinated. There's so much more that you can do than compromising your treatment and your long-term outcomes.
But and for some people it's the right thing to do.
It's
the right thing to do, and for other people it's not.
It depends on their situation. Yeah, I can appreciate that. So I wanted you to as well reiterate what your advice was for people who are on active treatment. Obviously, this is specific to certain individual cases, but what is your general advice to people who are currently having active treatment, and when do they get vaccinated?
So this is a really rough sort of thing. If you're having active treatment, and give me your opinions, Juliette and Julianne, but I would say I don't really mind. If you get access to the vaccine, go for it. It makes you feel better, all right? But I'm still probably going to want to vaccinate you next year when everyone's had their first vaccine and the time is there for the next round of vaccination, right?
Yeah.
because you probably won't respond too well.
And I think it depends if it's ongoing treatment that the patient will have for the next 5 years. You're not going to stop it to vaccinate the patient. So I will do the vaccination. But if it's, for example, chemo and it will be over in 1 month, maybe I would wait that the patient recovers some small immune response before doing the vaccine.
Yep.
So it will depend on the kind of treatment.
Because they'll be still eligible for the first round at the end of this year.
Mm-hmm.
So they're finishing, in August. So it'd be a great time to vaccinate them later. But, if a patient comes to me and tells me, I've got my Pfizer vaccine appointment next week, go for it. All right. But, we don't know whether it's going to. You should always treat yourself. If you have lymphoma, you should treat yourself as if you have not been vaccinated, whether or not you have.
Yeah, I think that's really good advice, actually. Julianne, this is probably a question for you, actually. Is there any evidence that people with gut lymphoma have a higher clotting risk with the Astrazeneca vaccine?
Good question. No evidence that I found. I had a quick look at that question beforehand. Of all the relatively rare cases of all of the people around the world that have had the Astrazeneca, those have had the VITT vaccine, there's not really been a sort of sub-analysis done of lymphoma patients in particular, and certainly not gut lymphoma specifically. Sort of obstruction of vessels and things by large masses and whatnot is sort of a different mechanism by which it's possible to have some coagulation, but that is quite a separate mechanism to the immune-based VITT sort of basis. So I don't think there's any evidence to say that in particular. Yeah.
Okay.
Julianne, I've got a good question for you from one of my favourite patients. For the 97% that develop a clot but don't die, are there any long-term effects?
I was just looking at that question. It's a great question, Glenn. So I think looking at clotting in particular, it is relevant in terms of the location and the extent of clot. And obviously this is alluding to patients who have clots, for other reasons aside from VITT as well. So obviously the more extensive the clot, the more the potential for prolonged treatment of anticoagulation and potential side effects. So we know patients with very extensive leg clots, for instance, right up to the groin, have more of a chance of having something called post-thrombotic syndrome, where, of course, a big old clot getting into your vein and damaging those valves, which otherwise help to clear the fluid from your leg, and really can leave you with some long-term effects in terms of swelling, irritation, ulceration of the skin, and some throbbing associated with that. So we see that in clotting patients in general. So the location of the clot is relevant. The important thing I think with VITT is there is a relevance in terms of the type of anticoagulation treatment. So without going too deep, we have some concerns in terms of using heparin. Heparin through a drip, or otherwise Clexane, which many of you who have been in hospital probably very familiar with, those little stinging injections to prevent clots. So because it had the VITT problem has a similar mechanism to a rare disorder called HIT, which is sort of like a reaction to heparin, which can set off that same cascade that I mentioned. We have not been using Clexane or heparin to treat the clots. So we really do have to use some other agents. And that's really the recommendation at the moment, is for long term to avoid that. So we don't have any evidence at the moment with the limited period of time that we've obviously had experience with this VITT entity to feel reassured that it's safe to ever be exposed to those anticoagulants in the future. So that has a little bit of a logistical input. We've been the few cases that we've sort of had involvement with in a direct sense, those are going up as a heparin allergy to avoid exposure in the future, with the concern that we may reactivate that same process. So it certainly does have some long-term effects from that perspective. In terms of the actual, the clot itself, really in the acute setting, the aim of providing appropriate blood thinner, of course, but also turning off that immune response with some steroids and some IVIG has been more sort of in the acute sort of setting. Of course, as I mentioned, with the extent of clotting and whatnot, it really does depend on the location as to what kind of long-term effects you may have as a side effect of the clotting itself. So I don't know if that was a roundabout way to slightly avoid the question, but short answer is yes, for a couple of reasons, and we don't sort of minimize the potential effects of certainly significant clotting and obviously the very rare circumstances of all the patients around the world that have had AstraZeneca who unfortunately have passed away, though minimal. It's still mindful of that impact, but we would still be treating people with significant clots in a similar way in terms of how we follow up the effects of that impact of the clot as we do with our other clotting patients. Yeah.
Julian, while I've got you on a roll, actually, another question's just come through as well too, and I think it probably does get asked quite a lot. But what about if you've had previous blood clots in the past? Is AstraZeneca safe to have?
It's a really good question, and a lot of our time in recent months have been spent trying to incorporate all the evidence that we have available, and certainly those top two references that I mentioned on the slides, the Thrombosis Hemostasis Society as well as the ATAGI group, have put out a wonderful guideline for us all to follow. The short answer is have a chat to your doctor. Your doctor will probably have a chat to us, which is the right thing to do. And we will all convene and be guided by this particular statement, which in essence has given us a short list of patients with very particular clotting disorders or particular sites that as a precaution we have been avoiding giving the AstraZeneca to. So just briefly, that'll include that rare entity that I mentioned, that sort of abnormal reaction to heparin, which sort of has a little bit of crossover and a similar mechanism to how the VITT works. We've asked all of the patients with a previous history of that to avoid having the AstraZeneca. Patients with previous rare clots in the unusual location, so that's the vein clots in the head called cerebral sinus thrombosis, and abdominal clots as well. Those in normal circumstances are very strange places to have a clot out of the blue. You might go on a plane and have a clot in the chest or in the legs. It's a lot more conventional locations to have a clot in normal circumstances. So certainly those sites are considered atypical, and because we've seen a lot of proportional increase in those sites, in particular with the VITT as a precaution, we've asked those patients to have the Pfizer vaccine. And I suppose also important to note, if you've had a very bad reaction to the first dose of your AstraZeneca in terms of marked kind of allergy, or certainly have been found to have had this VITT side effect, the subsequent dose is not advised. The only other thing is very rare clotting syndromes, and I think going into it in too much depth, probably not necessary, but Anti-Phospholipid Syndrome is sort of an antibody mediated type of rare clotting disorder, and given the antibody sort of basis to the mechanism for clotting, as a precaution we've sort of suggested that people avoid that as well. So I think getting a bit of guidance from your doctors and having a read of that ATAGI link, it has it all listed there, and certainly we are very happy to continue to be a little bit of a additional resource for advice to ask those questions as well. But for the most part, we've told our clotting patients, aside from those categories, go ahead with whatever you've been offered. Important to get vaccinated. We have no reason to think that anyone with clots for any other reasons have an increased risk of thrombosis in terms of the VITT particularly.
Yeah. I think I'm going to only ask one more question because I think that we could keep going all night. Otherwise, the amount of questions that are coming
I can't
through.
believe there's still 220 people there. And
Yeah.
I'm exhausted by the questions. Sorry.
I bet you are. I think as well too, I'll take this second to highlight it that any questions that we haven't actually answered, we will answer and share later as well too, just so that there's people not left hanging as well too. But I think for the final question, there's quite a few people who have been asking, how do you know if you're actually developing an immune response without antibody testing? Is there any way? Yeah.
No.
Yeah.
No. I mean, yes, there are in really robust clinical trials, but not every patient is on a clinical trial with, incredibly complex three-way antibody response, T-cell response, viral neutralization assays, which are really cool, where you get some of the patient's plasma and you add it to different COVID variants, Delta variant, Beta variant, Alpha variant, and see how much neutralization of the virus you actually do in the laboratory. No.
I like your short answer.
But we know that just remember 0.15% of the New York population who are vaccinated have got COVID. Right, 0.15%.
Yeah.
So was it they were of the proportion of the current COVID lot? And many of them will have been patients with lymphoma. We would have seen a huge increase in numbers of lymphoma patients getting COVID by now. We would have had a big, really big flag of that. And we haven't seen this massive increase.
Yeah.
Yeah. So I think we should be heartened by the real world absence of data.
Yeah, I think that that's a really good point, and that's probably a really good place to leave it actually. I'd like to take this opportunity to thank all three of you very much for donating your time and putting your effort into these presentations and staying with us so much longer as well too, to answer all of these questions. It's a very hot topic. So Mike, if we can go to the next slide as well too. I'd also like to take this opportunity to let everyone know about our upcoming patient symposium on the 15th of September. The theme for the symposium is to take charge and live well with your lymphoma or CLL. On this screen that you can see as well too, there's actually a QR code that's listed there where you can scan the QR code to register. If you're not QR code savvy, you can also hop on our website as well too, or send our nurse support line an email and we'll help you to register as well too. The event will also be held as a webinar, so everyone affected by lymphoma or CLL can have access to professionals who will be discussing topics relevant to every stage of your disease trajectory. So I'd like to just take this opportunity again to say thank you so much to you three wonderful ladies who have donated your time to do all of this, and thank you so much to all the patients and healthcare professionals who have made this session so interactive and asked so many questions. It's been very, very relevant and very topical, so thank you very much.
A pleasure. Thank you, Lymphoma Australia, for cobbling this together. I think it's probably the very first time you've got so many hundreds of patients together in just a few days. Yeah.
I think that's probably very true. I think it just goes to exactly. It goes to highlight how topical and how much need there is for all of this. So thank you very much, ladies.
Thank you all.
You're welcome.
Thanks.
Bye.
Bye.